Good afternoon, ladies and gentlemen. Thank you so much for coming today. I appreciate seeing everybody here, and on behalf of the Oceanside Healthy Aging Initiative, I would like to welcome you to an afternoon of information and education. My name is Laurie Amdam. I'm a nurse, and I work with seniors in spiritual health out of Nanaimo, and it has been a real privilege for me to work with the planning committee who put on the event this afternoon. And I think you're going to really enjoy it. We have a wonderful panel of speakers for you. And I just want to acknowledge a couple of people in the room who have put in countless hours and days of work for today. At the very back, standing up, is Mike. Sitting here, stand up, Mark, would you? This is Mark and Colette. Stand up, thank you. These are the folks who have done the planning for you. And our topic today is a really important one. All of us want information about dementia. Communities need to know about it in order to plan. Families need to know about it in order to care for their loved ones. And probably almost everybody in this room is concerned about knowledge so that we can optimize our own brain health and our own healthy aging for the future. So you're going to hear a little bit about all of those things today. Your questions and your comments are welcome. We will leave time at the end of every presentation for specific questions, and then, as you can see from your agenda, at the very end is time for a panel discussion. So if I can just direct you to your agenda for one moment. You see that we're going to get started right away. I'm stepping in today for Dennis, who was unable to be there with us. We're going to start with Dr. Marilyn Bader, talking about what dementia is and driving, and then we're going to have a break for some refreshments. So you can feel free to get up and walk around and talk to the display people and all of that. Jane and Tina are here from the Alzheimer's Society after the break. And lastly, Tanya is here from the detachment in Oceanside. And then finally, we will have questions and discussion to finish our afternoon. And Joan is at the back as well from Lifeline. Joan's been invaluable. Thank you, Joan, as well. So in the interest of brain health, which involves creativity and having a little bit of fun, can I ask, would you turn over your evaluation page and see if you have a smiley face? There's one person with a smiley face on the back of their evaluation form. Who got it? Who got the smiley face? Smiley face?
Yeah, but it's invisible.
It's invisible? Did anyone get a smiley face? You're sitting behind it. There you go. There's the smiley face. All right. And if I could encourage you, please, when we're done, to fill out this little yellow evaluation form, we would appreciate that, because your feedback helps us to plan future programs. Are there any questions or concerns that I can answer at this time? Okay, we'll get started then. And I would like to begin by introducing our first speaker. And it's an honor to introduce Dr. Marilyn Bader. She is the Vancouver Island Health Authority Chief of Geriatrics and also the Medical Director for the Seniors and Spiritual Health Division. She completed her medical training at the University of Alberta, followed by a residency in internal medicine and a fellowship in geriatric medicine. Speaking as someone who gets to work with Dr. Bader from time to time, I can tell you that we are lucky that she then moved to Victoria in 1992 and has worked as a consultant geriatrician for our island ever since. Please join me in welcoming Dr. Bader.
Thank you. I'm glad everyone took the time away from what is
probably the best gardening weather that we've had this spring to come here. I know that it's been a pretty miserable spring, and so my gardening is way behind, so I appreciate everybody coming here. And Lori, I need you to hook me, right? So I've been asked to, in 1 hour, talk about dementia and then talk about driving, both of which are really big topics. I'm going to a dementia conference at Harvard in June, which is 3 full 10-hour days, just on dementia. So trying to squash this into 20 minutes is going to be a bit tricky. So I can talk for a long time, so keep me on track. All of us, I think virtually everybody, nobody wants to get dementia. I turned 50, my self-surveillance has gone up, right? Because I am highly attuned to what it is, to what's normal and what's normal. And every time I forget something, I'm thinking, well, is this the start of it? Because you don't wake up one day and, ooh, you got dementia, and the day before you didn't. This is a process that goes on for years and years and years before anything clinical happens. And that's what we need to start to realize, is that it's stuff that we do in middle age that impacts what happens in our 70s and 80s. So I'll try to advance this. There we go. So we know that there's probably 15, 20 years before people have any subjective complaints about their memory. And that is really a pre-dementia state, right? There are changes that are happening at the level of the brain pathologically. You just don't have symptoms yet. Isn't that reassuring? There are changes that happen with aging, with memory. And most people think memory is short-term memory and long-term memory, and that's true. But memory is a lot more complicated. So you have reference memory. Reference memory starts to go in middle age. And reference memory is this. Someone told you something. You remember all the story. You remember all the details of the story. But when you go to relay it to somebody else, you can't remember who told you. Or you've read something and you can't remember where it was that you read it. That's happening to me now at 50, right? I can't remember who told me that, but I heard this. So that's normal, okay? That is not something we have to worry about. But as we get older, it does take you longer to learn something new. So the things that when you were 20, somebody gave you a phone number and you had it and it was there for the next 50 years, great. Now you have to go over and over and over before you remember what that number is. And it takes longer to retrieve it. So when you go to remember now what is your pharmacist number or whatever, it takes you a little longer to bring that back up. That's normal aging. As long as it comes back, right? Is when it doesn't come back that you got to think, there's something else happening. The other thing, of course, is that you don't multitask as well. Now, men don't multitask well anyway, so they don't notice. So men don't notice that, but women notice that, right? Because you're multitasking, you are cooking the Christmas dinner, you've got the timing of everything is different. You're setting the table, you're getting all that stuff organized. It becomes more effortful the older you get. So women notice that. Men just come to give advice about what it is that you're doing. How you sure you want to mash the potatoes that way? That's what my husband always says. Sure you want to do it that way? So they don't really notice that they're not doing that, because men tend to be more focused on one thing right through to the end, and then they move to the next thing. Women, because of the nature of what we do, we tend to multitask, which is really dividing our attention between different things. So we notice that it becomes more difficult over time. There are lots of different things that affect memory. the more anxious you are, the more less likely you are to remember things. So you get worried about your memory, thinking, oh my gosh, I'm really worried, I think I'm getting Alzheimer's. You actually make your memory worse, okay? If you're depressed, you just don't care. You don't pay attention to stuff, and you can't remember. There are lots of medical illnesses as well that will negatively impact your memory, and all of those things need to be ruled out. The thing with dementia, everybody thinks about dementia as it's Alzheimer's. Well, it's mostly Alzheimer's, but there are other diseases as well that affect memory, and we need to look at those. So, most people with dementia don't actually complain of memory loss. And that's because they worry about it before they have memory loss. And then once they actually have it, it's, there's nothing wrong with me.
Yeah.
My memory's as good as everybody else's my age, right? It's the ones who actually have probable normal aging. They're worried that, oh my God, am I forgetting more than what I'm supposed to? But once you actually have it, you lose the insight into that. And what's important about cognitive impairment is that these are the people who are more at risk for accidents in the car, at home as well. They're more at risk for delirium, which is an acute confusional state that happens if we have some kind of insult to our body. We're sick. We have surgery, something like that. Medical non-adherence means you're not listening to your doctor's advice. You're not taking the pills that are prescribed because you know better. And disability. All right? So the thing about dementia is if you look at all the people over the age of 65, it only represents 10% of that population. But if you look at the numbers of people aged 85 and up, it's at least 50%, right? So it becomes more prevalent the older we are. So I'm going to talk a little bit about MCI, which is called mild cognitive impairment, and there's an amnestic subtype, which means memory. So there's normal, and there's dementia, and there's the gray zone in between, which is MCI. All right, and so that's what we are seeing in our clinics, right? So the thing with MCI amnestic subtype, these are people who have complaints about their memory. They're not remembering the way they used to, and their spouse or their child or their friend or whatever says, yeah, that's true, they're not remembering the same way. Relative to how everybody else does in their age group, it might be a little different, but not much, right? And they still manage perfectly well. They do their own banking, they're driving, they're looking after their household, all that kind of stuff. No change functionally. These people are not demented because it hasn't impacted their function. They have memory impairment, but the thing with MCI is that 12-15% each year will slide into that more impaired zone where we could say, yeah, you've got a dementia. But some of them get better and bounce back into normal, and some of them just stay like that for a long time. Men have more MCI than women. Okay? Women have more dementia than men because women live longer. Okay? That's the difference. Men kick off before they develop dementia. That's what I think, anyway. So what is dementia? So dementia is an acquired syndrome of decline in your memory. So it's not the people who have some kind of developmental delay. It's not Down syndrome. It's not something like that. So it's acquired syndrome that affects your ability to function, but you're alert. So that takes out all the people who have chronic vegetative states, people who have been severely head injured and are in a coma for a long time. It gets worse. Memory loss always gets worse. And it robs you of your independence over time, right, with any of the dementias. It is not normal aging, okay? It's a disease process. And it is certainly different from the normal cognitive lapses that we all have. We all forget things. What we look for is when you're thinking and your memory, your ability to plan things, to execute things, to make decisions, impairs how you can manage with basic ADL, which are the normal dressing, eating, walking, toileting kind of stuff, or your instrumental ADL, that's the things you need to do to run a household. Pay your bills, go to the bank, drive, cook, shop, things like that. And then the get up and go test is what has to do with walking. Because the slower you walk, the more likely you are to have trouble with your memory. If you have trouble with your memory, you're more likely to walk slower. Not that slow walkers are going to get dementia. So I'll say what I'm talking. The thing about dementia too is it gets worse and worse and worse over time, right? So if you think of it, it's every 5 years you double the incidence. So if you have about 1% of people age 65 who have a dementia, then by 70 it's under 65 is 1%, 65 is 2%, by 70 it's 4%, and on it goes like this. And then of course you can, for individuals, there are other things that increase your chance of having dementia. And some of that is family history. It's not that my great aunt Bessie had got senile, whatever that means. But it's more like your mom has dementia, and her brother had dementia, and her parents had dementia. Ooh, that's something that's going to increase your risk just based on your genetics. So this is looking at what we're facing here in Canada. This is from the Alzheimer's Society, looking at the change over time from the dotted line is 2008, and this top line is 2038, the incidence of dementia. And as you can see, once you hit 70, 75, that's where it starts to take off. And over 85s here, big numbers. Now, even if half the people who are 85 have dementia, the overwhelming majority of those are not. So it's only, at least half of those will be mild. So then the others will be moderate or severe. But most people with dementia, most people, 55 to 60% of people with dementia are actually living at home. So that's important to remember. It's not that they're all in facilities. So what I do every day, try and figure out when people are complaining about memory, is it normal or is it something we need to worry about? Forgetting a name is a normal lapse. When the election was on, I was watching CBC. Besides being completely irritated that they didn't put green on and they kept calling it other. I come from Salish Gulf Islands. Yeah. We voted in our green person. They kept telling you about BC, what was happening locally in BC, which is great. If you turned to another station, CTV, they only told you what was happening in Ontario. And I kept saying, I'm like, well, what about that liberal guy in Saskatchewan, the finance critic, brush cut guy, R something. 2 hours later, Ralph Goodale's name came to my head. That is normal. That is truly normal. Not recognizing that you've ever seen that man's face before, not recognizing a family member, that's abnormal. Leaving the kettle on, that's okay. Well, it's not okay exactly, but I mean, it's normal. It happens. It's not something you want to do every day, but it's not a big problem. Forgetting that you have to serve a meal when you just finished preparing it, that's a problem. That's a big forget. Forgetting the kettle, minor forget. Not finding the right word, so searching to find that right word to put into a sentence. That's normal. We all have it. Standing in front of people, it happens more often. Putting the wrong words in, that's abnormal, right? Forgetting the date or the day happens easily. Happens particularly retired. Who cares? Weekends don't really matter. Right? For me, weekends matter. It's important for me to know the days and dates because that depends on when my unpaid chauffeuring job, driving my children to their activities, where I'm driving them to, right? So that's important that I remember that. Getting lost in your own neighborhood, that's a problem, right? So things, not balancing your checkbook, occasionally forgetting where your keys are, forgetting where you put your reading glasses. Oh, like, doesn't everybody have like 7? I do, because I'm always putting them down somewhere and forgetting them. Getting sad about things that truly are sad. Those are all things that are normal. What's not normal is not being able to recognize numbers, having really a huge amount of trouble with figuring out invoices. When you get your bill from the Visa and you can't figure out what's the number that you have to pay, that's a problem. Putting things away inappropriately. It says here iron in the freezer, it's milk in the cupboard, stuff like that. Having big mood swings. And its mood swings are, terribly sad over nothing, horribly angry over things that normally would just be an irritant. Those are things to worry about. And certainly personality changes. So lots of times when people are starting to have early changes with their cognition, there's a change in their personality. So we don't really hear about people all of a sudden becoming nicer. People don't really worry about that, but it's the ones that are more irritable and angry and obnoxious than usual. They were never like that before. Those are the ones that come to somebody's attention. The people who were kind of obnoxious before were suddenly nice. Everybody thinks it's a good thing. So they actually present later because people are not worried about the change. Dementia, first of all, you've got to rule out a delirium. And there's a video that we did on delirium that's out there. Delirium is a sudden change in your thinking. You have fluctuating changes so that sometimes you seem normal and sometimes you're definitely not. Always associated with poor attention, change in your attention. Either you're stuck in a loop and you can't kind of release your attention, so you're just on and on about the same thing over and over. Or you flip from talking, you just can't keep your attention focused anymore. And a change in your consciousness. So people who fall asleep mid-sentence and stuff, those people are delirious. I see it all the time in hospital. People come in, they're sick. Or they come in, they weren't sick, and then we did something to them. We do surgery. And that goes away. It goes away most of the time. Not all the time. 80% of the time it goes away. 1 in 5, there's still some cognitive changes that can take, 2 months, 3 months, sometimes 6 months later, there's still changes. If somebody has a bad delirium in the hospital, I've seen them, I also follow them to make sure that they get back to normal. Because if they don't, the delirium might have just unmasked an early dementing problem that we can now do something about. I want to make sure people aren't depressed. Because when you're depressed, you just don't care. You don't pay attention. It's all hopeless. So, the answer I don't know to everything, right? And just don't. So you need to rule out those. There's a whole bunch of medical problems that can affect your memory. Hypothyroidism, hyperthyroidism, hypercalcemia, kidney disease, liver disease, all that kind of stuff we need to look for. And then you have the dementias, the ones where there's been a permanent change in your thinking. Alzheimer's dementia, vascular dementia, Lewy body dementia. And then there are the weird and wonderfuls that there's dementia associated with Parkinson's disease. About 35% of people with Parkinson's disease end up with a dementia. Frontal lobe dementia, Pick's disease, alcohol. A little bit of alcohol goes a long way. So by the time you're maybe 75, probably your alcohol intake should be a third of what it was when you were 40, right? Because it takes far less to create the same effect. And what your mother told you about alcohol killing brain cells is true. So this is so half of that is Alzheimer's disease, of the people who have dementia. About 10 or 15% are vascular dementia. Another 15-20% are going to be mixed combination of Alzheimer's and vascular. And then Lewy body dementia, and then the others are another mishmash of about 10%. So Alzheimer's disease is a specific pathologic process that happens in the brain. All of us have it. Okay? If somebody were to take a piece of my brain out right now, hopefully a part that I wasn't using, they would see changes. It's just a question of how much and and whether or not it's making any functional difference, right? So the brain is gray matter, which are the cells, and white matter, which are the connections between the cells. And the white matter is exquisitely sensitive to changes in blood flow. So things like diabetes, high blood pressure affect the white matter. You can get big strokes where somebody was fine and then they have a big stroke, and they don't think the same way. But you can have little tiny strokes where you're not paralyzed and you're not numb and you still talk. But the white matter has been damaged, and it's like, nicking an insulated wire repeatedly. And your thinking processes are slowed down. You have to kind of do a detour around these little roadblocks. Every time you do that detour, sometimes you get back on the right track. Sometimes you go off on a tangent, right? So the thing about vascular dementia, sometimes people can do something, and 5 minutes later they go to do something else, and lo and behold, they can't do it. They can't think of it, they can't remember it. And 20 minutes later, they can. Very frustrating. People think they're faking. They're not faking. That's just the way it is. The thing about vascular dementia is that people maintain their social skills really well. Very good at distracting, so that families, and certainly their physicians who have them for 6 minutes, you can fake anybody out for 6 minutes. They don't know that you're having trouble with your memory, because you can distract and you can pull it. Anybody can pull anything together for 15 minutes, 6 minutes, 10 minutes. It's the longer time. The phone calls back and forth to the kids. Oh yeah, it's all good. You talk about the hockey game and stuff, but it doesn't mean that you necessarily know how to balance your checkbook and realize that the vacuum cleaner guy who sold you a new vacuum is the same one who sold you a new vacuum 2 months ago. Right? And then there's the combination. So over the age of 80, it's really hard to say that anybody is pure anything. They're mostly a combination. And so I think as our demographic ages, we're going to have more people who are considered mixed. They're a combination of the two, as opposed to one or the other. But Lewy body dementia is important to know because it's weird. Okay, so Lewy body dementia, it's faster progressing, and people have really vivid visual hallucinations, and they can fluctuate quite a lot, and very difficult dementia to manage. But it is about 10% of the population of dementia, and so those are people that one needs to be careful of, because our usual way of managing things doesn't work so well. And in the other category, the frontal temporal dementias are people who present early. They're presenting in their 50s and their 60s, and they're weird. They're bizarre behavior. So I don't know if you remember, it was probably 10 years ago, there's a surgeon in the eastern United States who carved his initials into somebody's stomach at the end of the surgery. Frontal temporal dementia, unquestionably. You know, because he had no idea that there's anything wrong with that. He was just signing his work. You know, and perfectly, perfectly able to do the surgery. It's just his decision making was bad. Frontotemporal dementia don't present with memory trouble. They present with weird behavior. Often they're seen by psychiatrists first, because people think something's off with them, and they are right. But they tend to present earlier than older, the other dementias, which tend to present later. Okay, so what do we do about it? Who's at risk? All of us are at risk. Okay, that's the first thing. The older we are, the more likely we are to have a dementia. And we'll talk about Alzheimer's right now because that's the most common, but it goes for all of them. The older we are, more likely we are to get demented. If we're women, we're more likely to get it because we live longer. Okay? If you don't have a lot of schooling, more likely to have trouble with cognition as you age. And the thought being that the more education you have, the more dendritic connections you have, the education forces brain cells to make connections with other brain cells. And so we know that with aging, those kind of get pared back a little. So if you have a whole bunch that need to be pruned, it's just kind of shifting you along so that it doesn't become obvious until later. Okay, whereas if you had 3 and you lost 2, well, it just shows up sooner. If you have a big family history of Alzheimer's, so if lots and lots of Alzheimer's disease in the family, something in that family is predisposing you to that. Now, it might be that you're all hypertensive diabetics who didn't go to school. But it is true, but there are certainly family predispositions. There are rarely there are autosomal dominant problems, like so genetic ones. Those usually present earlier. I'll talk about those later. The whole ApoE thing, which you sometimes see in newspapers and on the television, the ApoE lipoprotein we all have. And there are 2 alleles that are important. There's the E2 and the E4. So if you have E2 from either parent, you have not a 0 chance, but a less likely chance of getting Alzheimer's. If you have E4, you have not 100%, but a much greater chance of getting Alzheimer's. It is not good enough of a biomarker, nor is it responsible for enough of Alzheimer's disease to warrant anybody being screened for this, except in a research situation when you're trying to look at the genetics. Okay? So we don't offer that. We can do it. We send it over to Vancouver, but it's not, if you have E2, I can't say, oh, well, you're free. You're not going to have any problem, because that's not true. And, of course, then there's all the vascular dementias and Lewy body dementias and other things which we know far less about genetically. High blood pressure in middle age. Bad. Affects the white matter, and so more likely to have problems. And in some studies that were done actually in the early 90s, when some nuns actually, who of course had the very similar lifestyle, donated their brains on their deaths and had cognitive testing beforehand. What we found was that people who were considered normal on their testing and had Alzheimer's pathology in their brains, the difference between them and the ones who seemed to have a dementia were the amount of vascular changes that were in their brains as well. So paying attention to your high blood pressure in middle age, very important, getting that blood pressure down. Managing your diabetes in middle age also. Again, because that goes hand in hand with the high blood pressure. So there are some rare mutations that happen, the presenilin mutations. Those are autosomal dominant. People dement in their 30s and their 40s. Terrible, terrible disease to have. Big family of it in Colombia, in a village where they all married, and half the population dements in their 40s. Down syndrome. People who have Down syndrome in their 40s start having the changes of Alzheimer's. And people with Downs who live into their 40s and 50s will dement. And it looks exactly like Alzheimer's. And I've talked to you a little bit about the ApoE4. So what can we do to try and prevent Alzheimer's? The more education we have, the better. It doesn't protect us completely. I have lots of physicians and university professors in my practice who are dementing, but presumably I would have seen them earlier if they didn't have that education. People who do leisure things like gardening, and they're out and about and relieving stress and interested in other things tend to have less Alzheimer's. If you have good social networks, so people who are involved in things, less likely to have dementia. And that's probably because, just the act of following conversation that goes from person to person to person, and to being interested and participating in things has some protective effect. Red wine, in a third of the quantity that you used to drink it in. Maybe the Mediterranean diet, which is, the boring diet. Fruits and vegetables and healthy fats and stuff, yeah. And maybe ginkgo biloba. It's... I don't want you all to go out and buy it, but if you are already using it, well, it's okay. But, the studies are pretty hazy, but maybe it has some impact. Exercise helps, unfortunately. So even if it's just 30 minutes a day, and you can divide that into 3 10-minute walks, and that's good enough. You don't have to be sweating. Thank goodness. Doing something that's intellectually stimulating every day, whether it's doing the Sudoku or the crossword or whatever, it's all helpful. So controlling your blood pressure, maybe non-steroidal anti-inflammatories, and this comes from people noticed that people with rheumatoid arthritis didn't seem to have as much dementia. These massive amounts of anti-inflammatories. So maybe the actual studies that we've done on it so far, negative studies, doesn't seem to be. If you give somebody who has early dementia lots of anti-inflammatories, doesn't seem to make any difference to the progress. So there are, data's out. Again, I would never say, go and have aspirin, ibuprofen and stuff whenever you like, because there are consequences to that. But it's interesting. It might be something for the future. And metabolic syndrome, that's, fat diabetics with hypertension. So this is what happens with Alzheimer's. This is kind of a weird slide. But basically, as you deteriorate, first off, you get a mood problem. So lots of people with early Alzheimer's will present with depression, and people who've never had depression before. So if somebody comes to me, 75 or 80, and they're really depressed, and they've never had anything like that before, that's somebody I'm going to watch, because in 18 months or 2 years, they might start to have memory trouble. And then you have some change in your cognitive functioning. So you have mood problems, then you have memory problems, and then you have your dependence is impacted as your memory gets worse, as your ability to do things gets worse. Behavior problems are late, or they're moderate dementia. And then mocentricity, fancy word for meaning movement. Right, so then it really starts to impact how people walk. So, mild Alzheimer's, not knowing the date, having trouble naming things. So, you know, that thing on your list, it's, use it to tell the time. Yeah, the watch. Not remembering what your wife told you 5 minutes ago. Not being able to, for us, it's people not being able to copy simple designs, and certainly having no insight into it. So before they're worried that, they've got having senior moments and old timers disease, and then they start to get, when they actually have problems, there's nothing wrong with their memory. There's nothing wrong with their memory. They become more socially withdrawn because it's more difficult. More difficult to follow conversation, more difficult to do things. And the way to prevent that unease is to not do it, right? Become more irritable because people are pointing out that they're not remembering. Mood is changing, problems managing their finances. As it becomes more moderate, then you don't necessarily know where you are. You don't recognize necessarily that's the house that you were in. Man, no, I'm way behind. Having more trouble, getting lost. This is where delusions, hallucinations, believing things that aren't true, seeing things that aren't there, getting agitated, restless, depressed. Aphasia and apraxia. Aphasia is trouble with your language, trouble finding your words. Apraxia, trouble figuring out what a task is, breaking it down into its component parts and doing it in order. So, apraxia, not knowing how to use a remote control on the television. I have 5 for our new system at home. I'm apraxic. My kids know how to do it, thank God. And then severe, eventually, severe Alzheimer's is fetal position, in the bed, mute, being fed, right? Doubly incontinent. Most people don't get to that stage anymore, right? And that's just because something else happens. So this is what we can do about it, maybe. So this is what happens with dementia if we don't do anything. It just gets worse and worse and worse over time. We do have some symptomatic treatment. That's Aricept, Raminol, Exelon, Manitine. So it gets a little better and then gets worse, and it parallels this how bad it was going to be. So if we stop the medication, you just plummet from one line down to the next line, right? What we don't have is a disease-modifying drug yet, where we're actually going to change the course so that people don't get as bad as quickly. Once we get that, it will be much better for all of us. Driving in 15 minutes. I suggest to people every week that they should no longer be driving, because driving is not a right. It is a privilege. And I see people with cognitive impairment. And they always tell me, apparently I only see excellent drivers who never had an accident in their entire life. They all come to see me in my clinic. But, we don't want to... there are lots of other reasons for why people shouldn't drive as we get older. Medications and medical conditions are certainly foremost. And if I can find a medical condition that makes it so that the person shouldn't drive, it's much more palatable to them than because of their dementia. And certainly there are certain medical conditions that prevent you from driving anyway. So if you have a bad seizure disorder and you can't control your seizures and you continue to seize, obviously you can't be behind the wheel of a car. If you have diabetes that is so terrible that you have your blood pressure, blood sugars up and down all over the place, you should not be behind the wheel of a car. Period. Doesn't matter if you're 20 or if you're 80. Right? So for me, it's all about what it is about that individual that makes driving more risky. My parents at 80 and 77 feel that older drivers are being singled out, and that this is a bad thing, and that society is out to get them. They live on the Lower Mainland, which has a lot of traffic. So the time will come when they won't be driving, and it'll be their daughter who insists on it. But so far, so good. The thing is, there are lots of things that make it more risky for people as they age. Eyesight. So lots of problems with eyesight, and also it's not just about macular degeneration and cataracts and glaucoma and stuff. It's also about adapting to dark. So that when you go into a movie theater and the show's already started and it's dark, and you're trying to find your spouse. And when you were younger, it was much easier. My kids can zip to where my husband is sitting really fast. I have to stand there for a while until I dark adapt. And the older we get, by the time you're 75, it takes 260 times as long for you to be able to see well enough in the dark as it is. Right? So when you're driving at night then, and you get the glare of the headlights coming at you, afterwards, you're not seeing very well. And that's why many people curtail their night driving, because that starts earlier too, right? It doesn't all of a sudden you're 75 and you can't dark adapt, it's happening in middle age. Poor neck and trunk rotation as arthritis happens, right? So if you can't shoulder check, you really got to think about whether or not driving is really in your future. Lots and lots of people with trouble with rotator cuff injuries in their shoulders, osteoarthritis in the hips and knees, foot drops, all of those kinds of things, making it hard to move from one pedal to the other. Speed of movement, reflex time, all of that stuff. If you've got Parkinson's disease, your driving days are numbered. And if you see me, the number is small. Okay? Medications. And we put people on lots and lots of medications that affect their reflexes, their attention, make them sleepy, make them tired, and of course alcohol. And then there's dementia. So if I can find something in the top 6, I use that. So the reason why older adults are targeted, or feel that they're targeted, is because there aren't lots of spectacular crashes in older people, right? Like the big bad crash where somebody flips over multiple times and then smashes into a tree. That's the young person, not the old person. But for the number of miles driven, number of kilometers driven, then we see a curve that looks like this, right? So the young drivers and the old drivers for numbers of kilometers driven, and that's what's alarming. They tend to be lower impact, right? So you're not driving at speed. They are. They're often at intersections, right? And parking lots. Parksville here at 11:30 this morning. Stopped to get something for my daughter, and this fellow was pulling out of the handicap spot without looking, and there were other cars there. So we all just kind of backed away to let him out, because and parking lots are a big place for accidents. But the thing is that older people, when they have an accident, are more likely to be injured, and often fatally injured. And this is just the look at the casualties, like the numbers of people who are injured or fatally injured goes up the older you are. Older people.
That is a list for older people?
Yeah. Well, here's.
In what area and over what time?
This is from the projected change from 2006.
No, that's not what I asked.
Yes. So, sorry, what did you ask?
You have a chart that shows over the last 6 months how many people have been in an accident, and are they older people?
I don't have a chart that
Don't
says.
you think you should have one?
I don't have that. I mean, this is because.
I know.
Why not?
Because aren't you maybe saying things that aren't necessarily true then?
This is based on, I do have data based on numbers of kilometers driven, right? And this is just looking at fatalities in certain age groups.
Yeah, but what you're trying to do now is to manage people like myself who have just been classified as being a good possibility I will have Alzheimer's. And
But you're not diagnosed as having Alzheimer's, right? I mean, this is just.
no, I'm not. That's exactly right. I'm not diagnosed as having Alzheimer's. I don't know what it is, but anyways, there is a term that they use.
Yeah. So the thing is, this is just looking at. This is not dementia. This is just older. This is all drivers.
Then why bring it up?
Because it is important. Because dementia has a role in that, and I'll show you that later.
But couldn't the police or the motor vehicles department give you those kinds of statistics?
Well, this is from Transport Canada.
Let's Transport Canada. What about Parkville?
Well,
We could. I mean, if you wanted to come down to detachment, what we could do is
Well,
pull
I
the
don't think I'm
profile.
not. If you want me to, I'll spend an hour up here talking about it. I don't think
Maybe we'll just move on to the next slide.
Yeah, we'll kind of say that at the end, okay? So looking at fault crashes across Canada, there are lots of different reasons why, when you've been in a crash, looking at the different things that could have contributed to that medically. So looking at vision, you have a heart attack, you have a stroke, or a diabetic event. But cognitive issues are important. Well, and that's judgment. What it is about, making those decisions when you're driving at the time of a crash. And if you look at the number of dementia drivers that we have, people who have a diagnosis of dementia or are projected to have a diagnosis of dementia, because we don't catch them all, we think that 2.5% of the elderly are still driving while demented. So in the Victoria area, that means we've got 1,500 people who are driving while demented. Just to put it into a local context. So people with mild dementia have an 8-fold increase in the number of crashes as people who don't have dementia. That's what's important about that. And so there are people who are probably safe to drive while they have a dementia, and those are really early, very, very mild dementia patients, and people who have Alzheimer's or who have mixed dementias, not frontotemporal, not dementia with Lewy body. And if they're also medically or physically well. So once you have a cognitive impairment superimposed on some other medical issues, it becomes less likely that safety can be maintained. We have, in BC, we must report people to the motor vehicles licensing if we have concerns about their driving. So this is 10 quick points about dementia and driving and dementia, which we'll talk about. So if you have frontotemporal dementia, you can't drive, period. You're impulsive, and you make poor judgment decisions, so you cannot drive. If you have dementia with Lewy bodies, you can't drive because you have really vivid hallucinations that seem really real. So you react to them. If your dementia is affecting more than one of your instrumental ADL, so shopping, housework, your finances, ability to cook, getting lost, stuff like that, you really can't drive. Because that has to do with complex tasks. If your family is concerned, you probably can't drive. because family undercall problems with dementia and driving, right? So if they're concerned, mostly it's a problem. And what we're looking at from family and friend are actual collisions or near misses, getting lost, disregarding signs and lights, and just trouble determining who has the right of way. Visual spatial problems. So, and that's, when we are looking at cognition, we're asking people to do 2D and 3D figure drawing and to draw a clock. And if you can't do that, that's a visual spatial problem. And you need that to be able to navigate. So, any physical ability operating a car, if it can't be compensated. So if you're weak, either it's generalized weak or one side weakness. If you have significant loss of range of motion of your neck, range of motion of your hip or your knee, you really shouldn't be driving. And if you're poorly coordinated. So people who have Parkinson's disease, people who have ataxia, stuff like that, probably shouldn't be driving. If you have glaucoma, so you have tunnel vision, so you just see centrally. Macular degeneration, where you just see peripherally and the center is black. People who have cataracts, and cataracts, obviously you need to have them taken out, but while you're waiting for that, you can have trouble with glare before you even know that you have a cataract, and that's a problem. And if you have stroke, so you have visual field deficit, so that there's a part of your visual field is missing, so that even if you shoulder check, you're shoulder checking into your own big blind spot. So people like that need to not drive. Medications. Alcohol, benzodiazepines, those are sleeping medications, anti-anxiety meds, antipsychotics, the ones that help with behavior delusions, hallucinations. Muscle relaxants, they have that lovely commercial of the little dancing wooden person with the pins. Those muscle relaxants make people nuts, right? Because you get really tired and you can get really quite confused on them when you're older. Sedating antidepressants, antihistamines, as now that we're into seasonal allergies. Anticonvulsants, obviously, if you're taking them for pain medication. Trails A and B are visual, spatial, and executive functioning. I'll just show you what his Trails A is, just basically connect the dots. Trail B is more complicated, where you have to divide your attention through numbers and letters sequentially. So it's 1A, 2B, 3C. So this person obviously is having trouble, is getting lost and getting numbers back to back to back and missing out letters altogether. That is, Trail B actually is highly correlated with having trouble with driving. Reaction time, 12-inch, 25-centimeter ruler dropped, and you need to be able to catch it. Right? You can get 3 chances. Because that's reaction time. Right? You should catch it around the 9-inch mark. Poor judgment, and this is, like, what would you do? What would you do if you see a ball roll out in front of you, or what do you do? If you are told that you have Alzheimer's disease, do you ever think that that's going to require you to stop driving? The answer is yes. Yeah, if you get that diagnosis, you will be. And then there are behavioral issues. So less of a concern is people who are anxious and depressed and kind of apathetic. They're probably not a big problem because they're not going to do anything stupid because they're going to tend to stay at home, right? Or be too worried about doing it. It's the ones who are quite disinhibited and they're impulsive, and if they have hallucinations or delusions, those people are more likely to be problems behind the wheel. And just because I've had this year, just because your license is gone does not mean that you should get a scooter. Because we take people's scooter privileges away too. Because it's the thing is, people think that say you can't drive a car, well, you can have a scooter and you can still get around. But the thing is, it's still a motorized vehicle, and we've had a number of deaths in the Victoria area for sure from scooters, where people do, they still require intact judgment and thinking in order to navigate a scooter, and scooters have their place, but they're not a substitute for a car if you don't have a license. And that's the end.